All right, there we go. So, welcome everyone to Labor Induction 101. Tonight, we are going to be talking all about what the difference is between induction and augmentation, because we always have to kind of start with the basics so we're all on the same page. We're going to talk about three common reasons for induction. Those common reasons are big babies, babies that are small for gestational age, and reaching 39 weeks of pregnancy. Those are the topics we're going to cover tonight. And then we will talk about ways to help ensure effective communication with your providers so that you can be actively involved in decision making. If you are a birth professional joining us, you can use all of this information when working with clients. And obviously, if you're an expecting parent, this is stuff that might come up in your pregnancy. So, whether you are a professional or a parent joining tonight, thank you so much for being here. So let's see. Let me just share a real brief kind of background about who I am, and then I would love to hear from you guys in the chat. So my name is Brittany Sharp McCollum. I own Blossoming Bellies Holistic Birth Services, and I'm based on the East Coast in the greater Philadelphia area. I'm in New Jersey. I teach a whole lot of in-person classes and workshops in South Philadelphia, as well as in Cherry Hill, New Jersey. I have been a childbirth educator, birth doula, and lactation counselor for over 17 years. I work both with expecting parents for childbirth education and lactation support and doula work, and then I also create and facilitate continuing education workshops for perinatal professionals, including OBs, midwives, residents, nurses, doulas, and childbirth educators. I have four kids. I got into this work after my first son was born. He's now 18. And I have three others, 12, 9, and 3, 18, 12, 9, and 3. My birth with my first son really was not, it was not empowering. And I came out of it feeling like, wow, for such a transformational, life-changing event, I really should feel more positive about it. And so I kind of started diving into learning as much about birth as I could. And then went on to have three more births that felt a lot more empowering. My goal in everything that I do is to provide people with information so they know what their options are, to help them develop skills so that they can manage labor, they can manage communication, they can feel confident moving forward into their process. And then to work with perinatal professionals so that they can feel confident in their role and also tap into the physiology of labor, especially when it comes to things like incorporating effective movement, trauma-informed care, holding up autonomy for clients giving birth. I think that stuff is really important. And being able to work with both parents and professionals allows me a really unique opportunity to kind of get some insights into both of those different, demographics so that we are able to more effectively collaborate together in the laboring space. You can check out more of what I offer on my website. I'll just throw that in the chat here. It's blossomingbelliesbirth.com. I offer free, not well, sometimes free. I offer webinars monthly. This one is free. About every 4 months or so, we do a free webinar. Every other month, we do a paid webinar that has continuing education units with it. The paid webinars are $15, and again, they're live monthly webinars with recording access. But then every couple months, I like to do some free webinars too. The free webinars are really intended to be like childbirth education foundation for everyone, whether you're a professional or a parent. So definitely check out what's on there. I think at this point, we have about maybe 12 or 15 different free webinars. We talk about things like labor basics, cesarean birth, the pushing phase of labor. But then we also talk about things like prenatal nutrition and postpartum physical recovery and pumping and storing milk and things like that. So lots of great webinars on there for you to check out. You can find that on the website at blossomingbelliesbirth.com. Tonight, as I mentioned, as you know, we're talking all about induction, which is always a hot topic. We did an induction webinar a few years ago after the ARRIVE trial came out, but before we had any sort of additional research after the ARRIVE trial. And for those that are unsure of what that is, the ARRIVE trial is the research that was done that kind of shifted the recommendation to providers commonly saying, hey, you're 39 weeks pregnant, it's time to induce, or do you want to be induced? Before this ARRIVE trial came out, we really didn't have a recommendation to induce at 39 weeks, and now people experience that a lot. So we did a webinar soon after the ARRIVE trial came out, and that webinar was more about the methods that are used with induction, what the research says about actual clinical indications for induction, like what are the clinical indications for induction, and of course, as always, we talked about advocacy and effective communication. So that's another free webinar. You can find that on the website, but today's webinar is kind of like an extension extension of that. What we're going to analyze now is some of that research that has come out post-arrive. And then we're also going to be talking about two really common reasons that are not always clinically indicated for induction, which are having a big baby or your provider thinking you have a big baby, and having a small for gestational age baby. And we're kind of going to get into fetal growth restriction with that as well. So those are our topics for tonight. I love questions. As anyone who has taken classes with me knows, I really love questions. So please feel free to put any questions that you have in the chat as we go tonight. I'm not going to stop and read the questions as they come up, but at the end, my goal is to leave a few minutes to go through the chat and see if there are any questions that we didn't get to answer in the content that I plan to cover tonight. So if you guys just want to take a moment to put in the chat a little bit about yourselves, that would be awesome. If you're a parent, if you're a professional, you can put that in the chat. If you're a professional and you want to share what area you serve, that would be awesome, and like what your role is, you can put that in there. If you're a parent and you want to share where you live, maybe your neighbor is on here too and you didn't even know it, that's always nice. So feel free to post a little bit about yourselves in the chat here. So let's see. I'm not going to read through all of it because we could potentially have like 30 something things in the chat. So we'll just kind of take a look. We have South Jersey joining us. Welcome, Julie. We have Finger Lakes area of New York, home birth assistant, nurse doula. Wow, nurse doula, childbirth educator, lactation counselor. Awesome, working on IBCLC. Nice. Birth doula in Sonoma County, California, lactation specialist. Sicklerville, New Jersey, Mama 5 doula. Awesome. Expecting parent in Fairmount. Nice. Our first is due March 11th. Wonderful. Awesome. So keep that stuff coming. Turnersville, birth doula, pre and wait, my thing won't go down. There we go. Pre and postnatal Reiki practitioner, prenatal yoga teacher, Greater Philly area, labor and delivery nurse in Northeast PA. Expecting parents, welcome in Gloucester County. Volunteer doula in Burlington, Vermont. Awesome. Going back to school for midwifery. Fantastic. Prenatal and pediatric chiropractor. Yay, in Haddonfield. Birth doula in South Jersey. Oh my goodness, it's hard for me to keep up. Blackwood, New Jersey. Awesome. Gloucester County. Yay. So happy to have you guys here. Awesome. And please feel free to connect with each other in the chat if you want to. That's always nice, you know, especially if there's somebody in your area that you didn't know was there, or if you're a parent and there's another expecting parent local, definitely reach out. Philadelphia childbirth educator and marriage family therapist, birth doula, postpartum, pure lactation, and grief doula. Awesome. Expecting parent in Philly. Yay. Expecting parent in April based in Philly. Liz from Burlington County. Awesome. Awesome. So keep it coming in the chat and definitely keep connecting with each other because that's part of what this is all about. So thank you guys again for being here tonight. I'm really excited to have you. Just FYI, everyone will have access to the recording of this webinar for 1 month. So I will send it out in a follow-up email. One other thing that I just want to let you know that you can always add in the chat or reach out to me about later on is other topics that you want to see covered in webinars. I am always racking my brain to come up with topics that I think people want to learn more about, but it's always nice to have someone else do that work. So if you're like, hey, I want a webinar all about, I don't know, I don't know, I don't know, but prenatal nutrition or whatever. I already mentioned that earlier. But if you're like, I want to know about this, tell me, let me know, because if I don't feel that I could, you know, if I don't feel that I'm well versed enough in that topic to do a webinar on it, I love having guest presenters too. So I can always find somebody in our community who is someone that is an quote unquote expert on that topic. So please make sure that you let me know what you guys want to learn more about. And in the follow-up email, I'll actually send a link to a little Google form that I have that where you can submit your ideas for future webinars. You don't have to like facilitate them, just if you have ideas you want to share. Awesome. So let's go ahead and dive in. This is going to be more of a sedentary webinar. We're not really going to be getting up and moving around a lot. When I teach webinars about movement, obviously we get up, we try different positions, we do all sorts of fun stuff. We're going to do fun stuff tonight, but it's going to be more of us sitting rather than us kind of getting up and doing stuff. So if you need to move more than what I'm doing, please feel free to stretch and get up. And if you need to multitask, that is understandable and totally okay. But I hope you can at least listen in if you're multitasking. So tonight's all about labor induction 101, exploring common reasons for induction and open communication with providers. As I mentioned, put any questions that you have in the chat, and at the end I will kind of glance through the chat there and see if there are questions you guys have that I did not answer, and we'll go from there. So please remember that this is information. I'm not in a position to diagnose anything. I'm also not providing medical advice, and it's not the intention for this workshop or webinar to take the place of clinical care in labor and birth. The idea is that you'll take this information and use it to open up communication with your provider so that you can that you can be actively involved in decision making. And if you're a perinatal professional, the idea is that you take this information and then you share it with clients and you use it to help empower clients in their decision making. I am totally fine with you screenshotting stuff. I just ask that you use it for your own personal use. I totally don't mind, and actually, I would love for you to, share something on social media, but just, just make sure that like you're not posting the whole presentation on social media, that sort of thing. But yeah, you're absolutely welcome to take screenshots for your own use, and definitely, you can post on social media if you want. Um, Awesome. So let's move forward and talk about our objectives. Very simply, we're going to define induction versus augmentation. I think a lot of times, especially when I'm teaching childbirth education, there are a lot of words that, as an educator, I might be like, this is just part of my everyday language. But for a lot of people, there are subtle distinctions that they don't necessarily know about. So a lot of times, induction and augmentation are used interchangeably, but they're not quite the same thing. So we're going to define those so that we can all kind of start out at the same place. Then we will explore what the research says on three common reasons for induction, including big baby, small baby, and reaching 39 weeks of pregnancy. Why did I choose these? Did I just randomly choose these things out of a hat? No, I chose these three reasons for induction because this is what I've been hearing so much about recently. And maybe you can, put in the chat if you've also been hearing a lot about this or if you've been experiencing this in your pregnancy. These are probably the most common reasons that I hear about for people being induced. Um, Honestly, the reaching 39 weeks of pregnancy has been the most common one in the past, I'd say maybe 2 or 3 years, that I've been hearing for people being having that topic of induction brought up with their provider. But yeah, big baby, and then the opposite end of things, small baby. Those are seem to be some common reasons too. So if you're also experiencing that, let me know in the chat if that's something that you have been seeing a lot of. We have Margaret in the chat said, "Yep, I have a big baby." Yep, and my doctor has been talking about induction. Yeah. Any of the perinatal professionals in here find that their clients are dealing a lot with any of those reasons for induction? Anybody want to share anything? Um, yeah, maybe. Absolutely. Lots of small for gestational age. Yeah, that's the small baby. Lots of worries about that recently. Yeah. Okay, cool. Well, thank you for sharing that. So we're going to talk about that and what the research says. And as with any research, it's not always so clear cut, and that's kind of what makes these things tricky. So we're going to explore the research, and then we're going to talk about some maybe concerns with the common diagnoses that we see, as well as how we can, make decisions about those things when it's not so clear cut. And we will discuss effective prenatal communication in regards to induction. Communication is so, so important. And I think a lot of us get a little bit nervous talking with providers, or we feel like we don't have options when something is specifically said, like, hey, this is what we're going to do. But you always have options. And that's a really, really important thing to be aware of as you go into any sort of communication with your provider. Even if options are not shared openly with you, you always have options. And you always have the right to consent, to refuse, or to delay anything. And that's really important to understand as well. So let's first define induction versus augmentation. So induction of labor is when someone is not in labor and it's been decided between them and their provider that it may be best to get labor started. That would be induction of labor. So with induction of labor, somebody is typically not having contractions or noticeable contractions, and they head into the hospital most commonly to start this induction process. Birth centers do not do induction. I mean, they might do what we might consider like a natural method of induction. Sometimes birth centers recommend things like castor oil to induce labor. But a medical induction is something that's happening at the hospital. In some areas, the medical induction is started at the hospital and people are sent back home to go through the earlier parts of induction and then told to come back to the hospital. That's not something that I'm seeing in the Philadelphia area, but I have worked with people in other areas of the country who do have that as the norm to start an induction in the hospital, head home, spend the early phase of induction at home, and then head back to the hospital. The induction process can be lengthy. It averages about 2 to 3 days. It could be longer than that. Of course, it could be shorter than that. But people commonly think, oh, I'm going to be induced today, so I'm going to meet my baby today. And that's not typically how it works. Usually it's going to be at least 2 days or so of that process taking place. So induction is lengthy. It doesn't get babies out immediately. Augmentation is when somebody is already having contractions, and then it's decided that it's best or better to make contractions stronger, longer, and closer. So with augmentation, someone's already in labor or having consistent contractions, and it's decided that we need to move things along a little bit more intensely and augment the labor process. So this is really interesting if you take a look at these statistics, and I'm going to read through them. If you can't, if you're multitasking, I get it. It's evening, and many of you probably have kids, and you're like listening to this while you're doing 10 million other things. So I'm going to share everything that's on the slides. But for those of you that are visual learners, the information is here too. If you take a look at these statistics, we see that from between 2010 and 19, so between 1990 and 2010, the induction rate rose. It doubled. It doubled for every gestational age group. That's huge. In 1989, which is when they first started recording induction rates, the induction rate was 9% in 1989. By the time we get to 2020, which is the last year that we have somewhat decent statistics for when it comes to induction, we're at 31.37% of births are induced. Not augmented, this is induced. The person is not in labor and it's decided we're going to get this labor process started. So from 1989, when the rate was about 9%, to 2020, we now have the rate at about 31%, give or take. And this researcher in 2022 who reported this statistic literally stated in their conclusion that this number is likely underreported. And for anyone that's familiar with statistics in this country and why would we have an underreported statistic on something as serious as childbirth, well, our statistics on childbirth in this country are really terrible. Not only are they terrible for specific demographics, they are terrible in terms of their consistency as well, because we do not have standardized reporting from one hospital to the next, one state to the next, one region to the next. So this means that we often have things that are underreported. We might have some statistics that look high, some statistics that look low. We can find some very basic statistics on the CDC's website, but when it comes to things like epidural use or induction rates or augmentation rates, those are not things that are universally reported. And so we wind up in a situation where we rely on large scale research studies or observational studies that look back at data to determine statistics on the rates of things like induction epidural interventions in general. So this is why this researcher says this number is likely underreported. When it comes to augmentation, because we lack this standardized reporting, it's really difficult to even know, even to have any sort of idea as to what the rate of augmentation might be. For those of you that are here tonight, and maybe if you're a clinical provider here tonight, or even a doula, if you want to share in the chat what you think in your area the augmentation rates are, that would be really interesting to see. Induction, again, is when somebody's not in labor. We're going to try to get that person in labor. Augmentation is when someone's already in labor and it's decided that we need to move things along. So augmentation typically includes the use of Pitocin. It could also include the use of misoprostol, which is an ulcer medication that has an off-label use of using for induction or augmentation. Sometimes augmentation is done by breaking the bag of waters artificially, although research is really mixed on whether or not that's effective. And for first-time parents in spontaneous labor, research does not support breaking the bag of waters as a means of speeding things up. So what I would love for you guys to put in the chat, if you have a second to do that, would be what you think your augmentation rates are in your region. And we're not checking this data. This is just like what you think you might be seeing. Whether it's a hospital that you're working at or whether you're a doula in the community, if you have any numbers that you might want to share. I mean, I'll share a number that seems to be accurate for our area, which is the Philadelphia area. I have talked with labor and delivery nurses and providers in our area, and the augmentation rate in Philadelphia hospitals tends to be somewhere around 85%. So about 85% of the time, labor is augmented in some way. Maybe not induced, but augmented in some way. We have Hannah Rose saying, I'm thinking about 25 to 30% accurate since the Arrive trial. Augmentation rates in the area in Chicago is about 60 to 70%. Yeah. So interesting, right? To see how things can range so much from one region to the next. But also, we're seeing rates that are really high. Even 25%, which is in the low end of the numbers that we've given, even that's high, right? That means a quarter of people that are giving birth need to have their labors moved along faster. Interesting. Yeah, and Brittany said I was thinking around what you were saying. They're so high. Yeah, crazy, crazy. So you can see if we take a look at these stats, how the numbers increase. So in 2012, the CDC reported about 23% of singleton births were induced. The Listening to Mothers survey in 2013, if you're not familiar with that series of surveys, I would definitely check them out. People are interviewed about their birthing experiences. So much really wonderful information is in those surveys. There's several of them. They were done in the state of California. Anyway, Listening to Mothers survey in 2013 said that about 41% of people were induced. 2018, the rate's about 27%, and then again 2020, about 31%, give or take. And augmentation, we really don't have those accurate statistics for. Julie says in the chat, augmentation seems like it's always done unless natural labor progresses super fast on its own. Yep, there always seems to be a rush. Yeah, very common, especially in places that have do a high volume of births. All right, I'm going to share a tangent that really has nothing to do with what we're talking about, although it is birth related, so I guess it does have something to do with what we're talking about. But anyway, there is this obstetrician and professor Neil T. Shah. You may have heard of him before. He really fights hard for maternal health and and maternal justice and bringing awareness to like the maternity care crisis that we have in this country. And anyway, his name is Neil T. Shah, and he is a professor at Harvard, and he does a lot of research, and he's gotten more into like the tech side of things and like virtual stuff at this point when it comes to prenatal care and so forth. But anyway, he did a research study that looked at labor and delivery units around the country. And his goal with the study was to determine whether the number of rooms that they had were relative to the volume of births that they did. Meaning, like, if some place did a high number of births, did they have a high number of rooms? And if there was a hospital that did a small number of births, did they have fewer rooms available? And what his research actually found was that there was no correlation between the volume of births that hospitals did and the amount of rooms that they had available. That's crazy, right? You would think that a place that's doing a high volume of births would have a lot of rooms available, but that was not necessarily the case. And this is interesting because we do have a push to move things along faster, especially if we're looking at large hospitals that are doing a high volume of births. We are definitely seeing that for time purposes only, labor is often moved along. That's not what we're going to be talking about tonight. We do talk about that more in the other webinar from a few years back on induction. So if you want to check out more about that, you can always look back at that webinar. It's free. The recording is available on the website. So you can always check that out. We're not going to talk so much about that tonight, but I always find that study to be so interesting that there's no correlation between the volume of births that a hospital does and the amount of rooms they have available. Whew, oh my goodness. Okay, so we understand what induction and augmentation are. We understand the difference between the two. Let's move forward and start exploring a little bit more. So every time people talk about induction as like with their providers, it doesn't seem that risks of induction are discussed. It's often the benefits of induction that are talked about. So it's really important if you're truly going to make an evidence-based decision that you're able to weigh out benefit and risk for yourself, for your own individual situation. So when we're thinking about risk and benefit, we do want to talk about the benefits of induction because there absolutely can be. We also want to talk about the risks of induction because anytime we are offering up any sort of intervention, there's always going to be risks. Sometimes the benefits outweigh the risk. Other times the risks outweigh the benefit. And sometimes it's going to be very, very different from one person to the next. So it's really important to have this information so that you can figure out for your own individual preferences, priorities, circumstances, what is that risk versus benefit scale? What is that saying? So some of the benefits that we see, and these are all research-based. You can see the sources down below. Some of the benefits that we see with induction are the ability to schedule. So if you want a specific provider to be there, or if you want to kind of plan the birth around something happening in your life, I have had clients where they know that their partner is going to have to like be out of town, or thinking like something like the military, where they know that there's a certain point where their partner's not going to be able to be there. That might be a situation where scheduling comes into play. We know that induction can mitigate some risks due to pregnancy complications. For example, a common risk that's talked about in terms of mitigating it with induction is the potential for increased blood pressure as pregnancy progresses. We do know that statistically blood pressure is more likely to increase the further somebody gets into pregnancy, and so we can mitigate some of the risks with hypertension with induction. And we can see that here, lowers risk of developing hypertension. We also can avoid an unplanned, unassisted birth. That could be a benefit of induction. So this is something that we see in situations where people have a history of a fast labor. Let's say they had their first baby and barely made it to the hospital, right? Or they were at the hospital for an induction and they had their first baby in like 4 hours. So with a second baby or a third baby, there's often concern that that person is going to wind up having an unplanned home birth, an unplanned, unassisted home birth. And often to mitigate the concerns with that, they would then schedule an induction. So these are some of the benefits that we see with induction of labor. But we also see risks. And as I mentioned before, the risks are often not talked about quite as much. So we have increased risk of hemorrhage with induction and augmentation. We have decreased oxytocin release. What is the downside of a decreased oxytocin release? Well, for the parent that's birthing, it makes the contractions a lot more challenging. For the baby, we don't have a whole lot of long-term research that looks at the effects on the baby of not getting high releases of oxytocin during the labor process. So we don't necessarily know for the baby what those long-term side effects are of decreased oxytocin release. We do see increased risk of uterine rupture. We see increased risk of infection. We see increased cesarean risk. And we're going to talk more about that because one of the things that the ARRIVE trial showed was a decreased risk of cesarean birth if somebody was induced at 39 weeks of pregnancy. So we're going to unpack that a little bit more in just a bit. We also see increased use of epidural and the subsequent risks that go along with epidural medication. We see an increased risk of fetal distress, and we see an increased risk of respiratory illness. So these are things that we see that are concerning with induction. Does that mean that it's going to happen all across the board? Absolutely not. There are people that have inductions with very, very few, if any, of these risks. But there are also other people that experience all of these risks with their induction. The important thing is having the information so that the individual person is able to weigh it out and figure out for their circumstances what are the risks that they're comfortable with and how much do the benefits outweigh those risks. Okay, so we're going to explore these three common reasons for induction: big baby, small baby, and reaching 39 weeks of pregnancy. So we are going to take a look at the research on this, and we're going to talk about some of the concerns when there's a diagnosis of this. And then again, we're going to talk, towards the end of the session about how we can talk with providers and kind of weigh out all of that information and make the decision that feels best for you. So a big baby is defined as being either 8 pounds, 13 ounces, or 9 pounds, 15 ounces, or more. And so that's how we define a big baby. The concerns with a big baby, the biggest concern that providers have is the potential for the shoulders getting stuck. According to research, of all vaginal births, the shoulders getting stuck, which is referred to as shoulder dystocia, if you've heard that before, occurs about 0.2 to 3% of the time. So if we look at all vaginal births, shoulders getting stuck occur 0.2 to 3%. I'm sorry, 0.2 to 3% of the time. This also means, though, that there's at least a 97% chance that the shoulders won't get stuck. We have to be able and willing to look at the data from both sides, right? Because it totally changes our perspective on those numbers. For some people, it might affect their decision making. For others, it might not, but it's important to look at the data from all different sides. What's so interesting, though, is that this statistic is for all babies, right? For all vaginal births. But according to this research from 2023, the majority of shoulder dystocias still occur in non-diabetic mothers with average-sized infants, while many patients with diabetes or macrosomic infants do not have shoulder dystocia. So macrosomic just refers to big babies. So people who have diabetes, people who have big babies, oftentimes don't wind up having the shoulders stuck. Sometimes people who do not have diabetes, who have average-sized babies, do wind up with shoulders getting stuck. It's not so clear-cut as being able to say a big baby is always going to have their shoulders get stuck. Not necessarily. The majority of the time when shoulders get stuck are happening with average sized infants in parents that are not diabetic. And that's really, really important because when we think of big babies, we think of the concerns with big babies, or the concern of the shoulders getting stuck with big babies. And we think of the reasons for shoulders getting stuck as being a parent that's diabetic, a baby that's on the larger side. But in fact, what the research is saying is the majority of shoulder dystocias do not actually occur in people with those risk factors. The other concern with a big baby is pelvic floor or perineal damage to the parent. Interestingly, induction increases the risk of pelvic floor issues long term and perineal damage. So we may be trying to induce to mitigate the risk of a big baby increasing pelvic floor damage, but by inducing, we are increasing the risk of pelvic floor damage. So it's a bit of a catch-22 there. But these are common concerns we see with the big baby. I mean, I've heard stories of people and their providers an attempt at pushing, that person wound up having a cesarean. So it's really interesting just to see that sometimes the labor process is unfolding quite straightforward, and still providers will suggest something like that. And that could have been a situation with shoulders getting stuck, the concern, or it could be a concern about the pelvic floor. But important to understand that information. Concerns with diagnosing a big baby. Number one, ultrasound is just not accurate in the third trimester. In fact, 1 in 3 people are told that their baby will be big, but only 1 in 10 babies actually are big. So this is huge. Let's say that again. 1 in 3 people are told that their baby is going to be big, but only 1 in 10 babies are actually big. Ultrasound in the third trimester can be off by about a pound and a half, one direction or the other. So when we're looking at third trimester ultrasounds to determine the size of the baby, they are just not accurate. Sometimes people will say, well, what about palpation of the belly? What if an experienced provider is palpating the belly to determine the size of the baby? Research shows the palpation of the belly is just about the same in terms of accuracy as ultrasound. So it could be off in one direction by a pound and a half or another, one direction or the other by about a pound and a half. Um, we also have a concern, and this is like really like my wheelhouse right here. When we are concerned about big babies, we don't recognize the fact that the baby's head molds, the pelvis shifts, and movement can create more space for the baby. A bigger baby may require more time in navigating their way down through the pelvis, rotating through the mid pelvis, even during the pushing phase of labor, coming out of the outlet. But if we are able to encourage and support position changes and movement, that helps to shift the pelvic space, which gives the baby these little incremental bits of space to work with so they can keep making progress, keep coming down and potentially rotating through the mid-pelvis. So when we have these concerns about a big baby, we're often not taking into account the importance of movement, how the baby's head molds, and the need for the pelvic space to shift. And then another concern is that we often don't have discussion of benefit and risk. It's kind of like your baby is big, so we're going to recommend induction at 39 weeks, as opposed to we're concerned about the size of the baby. Here are some of the benefits of having a bigger baby. Bigger babies tend to be great at nursing. Here are some of the concerns that we see with having a bigger baby. Here are your options available to you. Here are the risks and benefits of each of these options. Most of the conversations people are having with providers aren't nearly as thorough as that. Doesn't mean they can't happen. Those conversations absolutely can happen and should be happening, but unfortunately it winds up meaning that the person themselves needs to be the one initiating that conversation. And that's hard if you don't even know that you have the option to initiate a conversation. And it's also hard when you don't have the language to initiate conversations. So we're going to talk more about that. So this is some of the concerns with big baby, most commonly shoulders getting stuck, and then secondary would be pelvic floor damage. And then we can see the concerns with those diagnoses as well. So according to Evidence-Based Birth from 2018, and you can find this in their podcast archive as well as their signature article on big babies, a provider thinking the baby is big increases the risk of cesarean birth without improved outcomes for parent or baby. So the provider's thought on the size of the baby has an impact on how that labor is managed without improving outcomes for the parent or the baby. So again, it's really, really important to be part of that decision making. so that you're not just subjected to the potential bias or maybe liability that providers are thinking about when they are diagnosing a big baby. Um, yeah, so we will, I know there's a lot of stuff in the chat, so we will definitely check that out in a little bit. But let's talk about the flip side of things. Let's talk about a small baby because that's another common reason given. So it's like your baby is too big or your baby is too small. But what about all those little average babies in the middle? So small for gestational age is referred to as SGA. FGR is fetal growth restriction. That's different. That's like a subset of SGA, and fetal growth restriction is a more clinically concerning, it is a clinically concerning diagnosis. Small for gestational age is a little bit of a kind of like a gray area here. So small for gestational age is defined as a predicted weight or abdominal circumference less than the 10th percentile, meaning that about 90% or more of babies are larger than the size of this baby that has been diagnosed with small for gestational age. The thing is that small for gestational age, it's gestational, right? So gestational, we're talking about pregnancy. So this is a diagnosis given in pregnancy. Some babies who are small for gestational age will develop fetal growth restriction, which can be very concerning, but many babies will be born healthy. Many babies will just be on the smaller side, or maybe not if the ultrasound was just not super accurate, right? And usually when SGA is diagnosed, it's not just one ultrasound. There's going to be a series of ultrasounds that are looked at. So we're kind of looking at that fetal like growth velocity. Uh, but that being said, it is important to take note that ultrasound is notoriously inaccurate. Um, there are a few things that increase the risk of fetal growth restriction, which would be concerning. That would be placental dysfunction and preeclampsia. So if we have a baby that has already been diagnosed as small for gestational age, and there is suspected placental dysfunction and or preeclampsia diagnosis, those things increase the likelihood of that SGA baby actually being FGR, fetal growth restricted. I do want to point this out. So the next thing that we have listed here, higher BMI and higher weight gain decreases the risk of small for gestational age. We have so much bias in the medical world as well as the obstetrical and midwifery world against people in larger bodies. We hear so much negativity about people in larger bodies and potential outcomes. And I think it's really important to highlight some of the areas that where we don't see that negativity, where we actually see like some really positive stuff shown in research, and research has biases, of course, but we see some positive stuff shown in research for people who have higher BMIs and higher weight gain in pregnancy. And one of those things is that higher BMI and higher weight gain decrease the likelihood of small for gestational age. So we have that protective factor for babies. So I think that's important to point out. There's a really fantastic book if you haven't read it. It's called Fat Birth. I can put that in the chat. I hope I'm getting the name of it correct. And it talks about the bias that we see in both obstetrical and midwifery care, as well as the research against people in larger bodies. So definitely worth checking that out. Just put it in the chat in case you're interested. Okay, so let's figure out, let's kind of understand the diagnosis and the recommendations a little bit more. The challenge that providers have when a baby seems to be small for gestational age is determining who's actually at risk and who is not at risk. Because a baby could be small for gestational age and be born totally healthy, or a baby could be small for gestational age and wind up with complications. And until the baby is born, there's really not a way to clearly understand which babies are going to be healthy and which babies are not. This means that providers are more likely to take a risk-averse approach, meaning because they can't clearly say, okay, this baby's going to be healthy and this baby's not, they're just going to not assume, they're going to act as if all babies may not be healthy so that they don't run that risk of missing a situation where a baby would be unhealthy. So providers take this risk-averse approach. And if we put ourselves in the mind of providers, if you are a provider here, it makes sense, right? Because you can't clearly kind of delineate between babies that are small for gestational age and will be healthy and those who won't be. So it's understandable to take a risk-averse approach, but then that also is an approach that increases the risks associated with something like induction in a situation where there may not be benefit, but we don't know that until after the baby is born. Routine third trimester ultrasounds to detect small for gestational age are not conclusive, so we can't just rely on ultrasounds. It's only when fetal growth velocity was combined with biometry, so this did like statistical analysis of measurements, was there an at-risk subset that could be determined. So only when we routinely had the fetal growth velocity and the statistical analysis of measurements combined was there an at-risk subset of SGA that we could then say, all right, this group is more at risk, so maybe we need to intervene. But the routine use of this, the routine use of combining fetal growth velocity and biometry would increase the risk of false positives. So it's not something that we can just do all across the board because it would increase the likelihood of increase the likelihood of babies being put into that subset that actually don't need to be in that subset. And then in addition to that, you have all the potential risks that go along with repeated ultrasounds in late pregnancy as well. So it's a challenging situation for providers and it's a challenging situation for parents. And this is a situation where a lot of parents do go along with the provider because of that risk averse approach. And there's not a right answer. It's about doing what feels right to you based on the information that we have. Um, so let's move on from this one. And again, we'll talk more about how to talk with your provider and gather as much information as possible. But let's move on here. I want to share this quote from Henty Goer. If anybody does not know who she is, she wrote The Thinking Woman's Guide to a Better Birth. She does a lot of really thorough blog posts for the Lamaze website. She has a newer book out as well. Her Instagram is full of good information, so definitely check her out. But she wrote this article called Healthy Diet and Mindfulness Reduce Small for Gestational Age Babies. And this is, there was research that said having a healthy diet, using mindfulness practices can reduce the likelihood of an SGA baby. So this statistic is from 2022. She analyzed this research, but then she found a lot of flaws in the research, and this research is considered to be low quality. So then in the article where she was analyzing the research, she kind of shifted gears and talked about this other program, which was what we're going to look at right now, this other program that showed really significantly improved outcomes for parents with a different type of maternity care. So she kind of shifted away from the study that she was actually looking at that focused on diet and mindfulness and said, here's a program that's implementing a different type of maternity care, and they're seeing really great outcomes. So in the Strong Start program, that's what the program is called, midwives provide primary care, and this includes structured relationship building, time-intensive care, and individualized education. So different from the type of maternity care that the average person is receiving in pregnancy in this country. So this Strong Start program had this relationship building, time intensive, so not 15-minute prenatal appointments, and individualized education. There's very little education happening at the average prenatal visit. So this is a very different approach to providing support at prenatal visits. Participants in the Strong Start program were less than half as likely to give birth before 37 weeks, 4% versus 10% for those not in the Strong Start program, and half as likely to have a baby weighing less than 5.5 pounds, 4% versus 8%. Zeroing in on Black participants versus Black women nationally, the decreases in rates of preterm birth, 5 versus 14%, and low birth weight, 6 versus 14%, were even more marked. So basically, what this program is saying is that yes, we can implement things like healthy diet and mindfulness, which takes a lot of like getting people on board, right? But we could also change the way that we provide care in this country, and that alone has the ability to improve outcomes, particularly for demographics that are at higher risk. And that is higher risk due to institutionalized racism. So changing the way that we provide maternity care is really important. And I love that she highlights this in here. So if you wanted to check out the full article, you can just Google Henty Goer 2022 Healthy Diet and Mindfulness, and it'll come right up. All right, let's move on. Let's talk about this 39-week induction. This is probably the most common reason that I hear for people being induced. And this is mostly based on the ARRIVE trial. The ARRIVE trial was a research study that looked at thousands of people that were giving birth, and they kind of put them into two groups, induction at 39 weeks or expected management after that point. It was not a double-blind study. It would be hard to blind providers to the induction process. And they were, they went into the study wondering if induction had an impact on neonatal outcomes. And what they actually found was that there was not a significant difference on neonatal outcomes, but induction at 39 weeks in the ARRIVE trial lowered the cesarean rate. It also lowered the risk of hypertension. There was no impact on serious health issues or stillbirth for babies. There was a slightly decreased risk of respiratory issues in babies that were induced, and therefore a shorter hospital stay for induced babies. As soon as this study came out, I would say, I mean, honestly, as a doula that was practicing before and after and during the ARRIVE trial, I feel like it didn't, the whole study didn't even come out. Just the abstract came out, and all of a sudden there was like all this buzz about like inducing at 39 weeks. But interestingly, it's really difficult to take that research and then actually replicate it in labor and delivery rooms all around the country. So what wound up happening is that we have this research that has now led to a lot of providers saying, okay, we're going to induce 30 at 39 weeks. We're going to offer induction without much discussion at 39 weeks, but we're not necessarily seeing the same outcomes that we're seeing in the ARRIVE trial. So research post-ARRIVE has mixed results on cesarean rates and whether or not 39-week induction increases or decreases cesarean rates. There are mixed results on whether 39-week induction decreases or increases the risk of hypertension, or not increases, but whether it decreases the risk of hypertension. We have mixed results on outcomes for babies, and outcomes for babies include NICU admission, serious health issues, stillbirth, and shoulder dystocia. Mixed results. We have not been able in real life practice to see the same consistency in results that we saw with the 39-week ARRIVE trial. So when people are blindly being sold 39-week induction and saying if we induce at this point it'll lower your risk of cesarean rate, it's not so clear cut as that because the research has not shown that to be consistently the case since the implementation of routine 39-week induction. So this means that we really need to, again, make sure that we are making decisions based on individual preferences, priorities, lifestyle, beliefs, values, as well as the research, as well as a trusted care provider recommendation. And I will review all of that again in a minute. But that is the evidence-based decision-making model of care, which is considered the gold standard in the medical community. It means that individualized care is happening. It's not simply we're going to do this to every single person that comes in here, but instead it's here's what the recommendation is from a trusted care provider where there's ideally been relationship building, like we talked about before. Here's what the research says. And now how does that fit with the individual person's preferences, priorities, beliefs, values, lifestyle? That's evidence-based decision making. Okay, so I want to share this with you. Again, this is another quote from Hensi Goer, and I think this is important to take into account, especially when we're thinking about the ARRIVE trial. Comparing induction in a particular week with pregnancies allowed to continue after that week leaves out pregnancies in which labor began spontaneously during that week. It's like comparing apples and oranges, right? Comparing induction in week 39 with pregnancies that went further than 39 weeks is like comparing two totally different groups of things, right? So instead, ideally, what we should be comparing is, let's say again, for example, induction at 39 weeks versus people who went into spontaneous labor at 39 weeks. And if you include those pregnancies in the calculation, cesarean is more likely with induction. So let's read this one more time. Comparing induction in a particular week with pregnancies allowed to continue after that week leaves out pregnancies in which labor began spontaneously during that week. If you include these pregnancies in the calculation, cesarean is more likely with induction. So interesting, right? All right, so let's talk about advocacy. And I know I'm probably already keeping you guys too late because I have a tendency to do that. Oh, no, we're doing pretty good with time. Okay, so let's talk about prenatal discussion and advocacy. As I've been saying all along, there is no clear-cut right or wrong answer. It is about figuring out what feels right for the individual person. There are a few things that I would suggest to get comfortable having open conversations with your provider and learning, exploring how to advocate for yourself. And that's a life skill. That's not a birth skill. And you might want to go along with every single thing that's recommended, but still having the skills of advocacy means that you're part of that decision making. And that's what leads to improved birth satisfaction. So one of the things that I always recommend to people, first and foremost, get comfortable from the very beginning with asking questions and follow-up questions. And I should also add in there open-ended questions. For anyone on here that's taken birth classes with me, that's one of the things that I always talk about. Open-ended questions. Do not just ask questions that your provider can answer with a yes or no response, because that's not a conversation starter. Instead, we want to have a conversation, so we want questions that are open-ended. So now we have things to kind of talk about. We have follow-up questions based on the information provided. So get comfortable from the beginning with asking questions and asking follow-up questions. If you are somebody that feels a little nervous doing that, I have 2 tips. Number one, write your questions down. Write them down in advance, literally on a piece of paper or on your phone, and bring them with you so that you don't have to remember them in the moment. Number two, have a support person with you. It could be your partner, it could be a friend, a family member, maybe it could be your doula, it could be your sister. Have somebody there with you so that you have a little bit of support, so that you don't feel like you're alone asking these questions. That can feel intimidating. There's definitely this sense of authority that a provider has over the person giving birth. But remember, the person giving birth, they're the ones that are the true authority on their body. But having a support person by their side can make a really big difference in terms of their confidence in asking questions. As we've already talked about, use the evidence-based decision-making process every step of the way. This is even with things that you don't really care so much about, still think through that evidence-based decision-making process because it's all about practice. It's all about developing the skill of advocacy. So if you are in a situation where a provider is recommending an ultrasound at 20 weeks, which is really common, most of us are going to go have an ultrasound at 20 weeks and not think twice about it. It's not that I'm saying this so that you don't go and have your 20-week ultrasound. I'm saying this so that you can be part of that decision making. So think about that 20-week ultrasound. Think about the research. Think about your provider recommendation. Think about your individual preferences. It's practice in figuring out how you're going to utilize all of those components for decisions down the road that may not be so clear cut. So use evidence-based decision making every chance that you get. And that is a life skill as well. With evidence-based decision making, this is something that you can use like when you go to the vet with your dog, or you go to the car mechanics and they're telling you you need new brakes. Like, hey, let's use the evidence-based decision making process. We have our provider recommendation. Let's talk about the research on my brakes at this point, and the situation that I'm in versus what I would be in if I had new brakes. And then think about your individual preferences too, right? So no matter where we are, we're trying to weigh out all these different things anytime we're making decisions because we're developing the skill of using the evidence-based decision-making process. Ask questions. So ask follow-up questions, ask questions about what's being recommended. This is my list of questions. I know people like to use the BRAIN acronym, which is benefit, risk, alternatives, intuition, and nothing. But I feel like for somebody that's just looking at that, unless you are very well versed in these questions, looking at the BRAIN acronym is not necessarily going to help you in the moment. So I'm actually a big fan of the full-on questions, literally committing these to memory, writing them down, making sure your support people in the laboring space as well as at prenatal visits understand these questions, because again, these are life skills, not just birth skills. So we always want to ask, what does the procedure entail? What does recent research say about this? What are the risks and benefits? What are the alternatives and their risks and benefits? And then, especially when it comes to things related to labor and birth, what happens if we wait and do nothing? And then we always follow that up with how likely is it that something would happen? This also brings me to another point, which is relative versus absolute risk. Relative risk is the risk in relation to something else. Absolute risk is the actual likelihood of that risk happening. So for example, somebody could say, well, there's a 50% greater risk. That sounds high. I mean, if we think about that, like if that's the only information we're given, we're probably like, wow, that's a big risk. But that could literally be the difference between a 0.4% likelihood and a 0.6% likelihood. 0.6% is 50% higher than 0.4%. So if your provider gives you a relative risk, that's important to understand for sure, but then also ask for the absolute risk and then flip those numbers. Because if now you're saying, okay, the risk is 0.6%, that seems like, well, that was a jump from before, so maybe that makes me a little bit nervous. But that's also the same as saying there's a 99.4% chance that everything's going to be fine. Weigh things out from every direction so that you feel most comfortable with whatever decision it is that you make. Not that it has to sway your decision, just that you have to be able to see the numbers from all angles to truly understand what you are and are not comfortable with. Okay, here are a few other tips. When faced with a recommendation, take time to think about it before making a decision. If like, let's say again, for example, the 39-week induction, if you're at your 38 weeks and 5-day appointment and your provider says, okay, well, let's get you on the books for induction at 39 weeks. And you're like, well, I'm not really sure. Sometimes things are said like, well, it's best to get you on the schedule because if you decide later on you want to, we might not have room for you. Well, if they don't have room for you, then is that induction really necessary in the first place? Because if it was truly medically necessary, they would make sure that there's room for you. But sometimes people are kind of like gently pushed into making this decision on the spot. And it's really important to be in your own space when you're making a decision and potentially talk it through with a trusted partner or, birth support person, family member, because it's a lot easier to see things from all angles and to take the time to kind of sort through all of that information when you've taken a step back and you're in your own space. So when faced with a recommendation, take the time to think about it prior to making a decision. And then make yourself comfortable declining or delaying things. Not that you have to, but just because, again, it's a life skill to be able to say, no, thank you, I'm not interested, or I'm not choosing to do that at this point. Even if your plan is not to refuse, you can still practice this leading up to that point. So practice this with situations where you are comfortable declining or refusing something. Practice the language that you're going to use. I'm not comfortable with that right now. No, thank you. Even if your plan ultimately, for whatever it is not to refuse, we still want to get comfortable declining or delaying things because that is a life skill that will serve you really well when you come into a situation where you do want to decline or delay things. So these are just some tips to help you with those prenatal discussions that ideally you should be having with providers. So make sure you go into your prenatal visits, or if you're a doula here or a provider, leaving that space to have that open communication is important. So talking with clients about the importance of that, of having conversations, of demanding a little more time, it means that then you're starting to push for that individualized care. And individualized care is really at the heart of improving physical outcomes as well as emotional outcomes for parents and babies. So this is a quote from the American Family Physician Journal from their Choosing Wisely recommendation series. And it says, don't promote induction or augmentation of labor, and don't induce or augment labor without a medical indication. Spontaneous labor is safest for woman and infant, with benefits that improve safety and promote short and long-term maternal and infant health. So spontaneous labor, the kind of unmanaged labor process, is what we would think of as physiological labor. And research does support physiological labor for the vast majority of people being the healthiest process. And then from there, when necessary, intervention will carry benefit, possibly risk, but the benefit would outweigh the risk. So for your own individual circumstances, it's really important that you make decisions where you've weighed out benefit and risk, and you see or you feel that there's greater benefit, and that way you can move forward feeling good about the decision that you've made. So our quick takeaway tonight: induction is a common recommendation for a variety of reasons. We go over clinical indications for induction in the earlier webinar, so definitely check that out, the other induction webinar that we have. It's free, available to anyone and everyone. And then also keep in mind the not so clear-cut indications for induction, which we covered tonight: big babies, small babies, and 39 weeks of pregnancy. Making a decision based on research, provider recommendation, and your individual preferences can help mitigate risk and improve physical and emotional outcomes. That is the evidence-based decision-making process. What is my trusted care provider recommending? What does the research say about this? What are my own individual preferences and priorities? And developing communication skills prior to late pregnancy is a way to maintain a sense of control, involvement, and autonomy in your birth experience. Developing communication skills, I mean, this is a life skill, not just a birth skill. So practice this every chance you get so that you feel more confident in that situation in late pregnancy, because then you can really utilize those skills in a way that will impact the way you kind of move forward through your birth process. So if you want to follow along with me on social media so you get updates about upcoming free webinars and things like that, you can find me at Blossoming Belly's Birth. I like to post a lot of research-based information as well as things on movement, common interventions that come up in labor, advocacy skills, cesarean birth, supporting cesarean healing, postpartum stuff, all sorts of good things. So hopefully you'll follow along on there if you're not already. So I want to just come and check out what's in the chat before we move on. So let's see. We have Julie in the chat. MFM ultrasound was off 2 pounds a couple days before I delivered. 2 pounds, that's significant. I hate they go by this. It creates so much fear to the parent when often not necessary. She was actually estimated at 6 pounds and she was 8 pounds. Wow. Okay, here we have a question from Sarah. Any info on what the rate of shoulder dystocia is for subsequent births when previously experienced a shoulder dystocia? Yes, good question. So it's greater than 10% likelihood. That's the statistic that we have. When somebody experienced a prior shoulder dystocia, their risk for shoulder dystocia in their next pregnancy is greater than 10%. That's the statistic, greater than 10%, which could be a whole lot of numbers, but greater than 10% is the statistic for that. And keep in mind, for all vaginal births, the risk for shoulder dystocia is 0.2 to 3%. Um, my sister's second was measuring at 10 pounds, ended up being 8. Yep, yep. Rebecca says, so often I get parents concerned that they were told their baby was too big and ended up being 2 pounds less than predicted. That's wild, yeah. Um, so David has a question. When the shoulders don't pass, then what methods do they intervene with and what are the risks associated with those? Great question. So when the head is out and the shoulders are in, or if the head is not fully out, just out to about the brow, which is considered a true shoulder dystocia, there are methods that they can do to intervene. So the common method is called McRoberts maneuver. So it has the person lying on their back and their legs get pulled really, 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 really far back. And then there's suprapubic pressure, so pressure pressed on just above the pubic bones to kind of push the baby's shoulder down. And sometimes that includes cutting in episiotomy and the provider kind of manipulating the baby out. So it does tend to get babies out very quickly, but it can be a very traumatic situation for the parent. And then in other situations, if there are still challenges getting the baby out, they can break the baby's collarbone, and that will often allow the baby to come out easily. Um, let's see, fat birth. Fat birth is a great read. Yes. Let's see. Um, We have a question in the chat. My doctor recommended induction around my due date because my gestational diabetes is becoming increasingly uncontrolled, but I've not been told by my that my baby is too big. Do you know what the reason might be for this recommendation? So the concern with uncontrolled blood sugar when there is true diabetes or gestational diabetes is that it could cause a sharp drop in the baby's blood sugar after birth. So it's not only about the concern about big babies, but the concern about blood sugar levels in the baby after birth. Evidence-Based Birth has a really great article on gestational diabetes and induction for gestational diabetes. So I would definitely suggest that resource for all the available research, as well as a nice little easy conclusion section that you can check out. And I'm not associated with evidence-based birth. I just really do value them as a really wonderful resource. And their research is just their articles are just so great. So yeah, so definitely check out the evidence-based birth article on gestational diabetes and induction for gestational diabetes. Yes, and Hannah put something in the chat that I didn't say in response to David's question. Midwives will use the Gaskin maneuver. So I think it does depend on where the midwife is working. So David had asked, what do they do if the shoulders are stuck? And Hannah Rose put, midwives will use the gas maneuver. Yeah, so the gas maneuver is a just basically just move somebody into an all fours position. But typically, if somebody is side lying, or if somebody's squatting, or if somebody is on their back, the significant movement of getting them into that all fours position shifts their pelvic space so much that often it's that movement, not even necessarily the all fours position that they wind up in, that allows for those shoulders to come out. In a home birth, for example, that would be one of the first things that they do if there's a concern about the shoulders. I have seen a few shoulder dystocias in hospitals with midwives, and I've never seen them use the Gaskin maneuver. I've always seen them use the McRoberts maneuver. Actually, that's not true. There was one that I did see them use the Gaskin maneuver. And they did eventually wind up getting her onto her back and doing McRoberts after the Gaskin. But honestly, I think like there was so much movement happening there that that movement probably is what helped to work those shoulders out. But yeah, the gas maneuver is another option. It's a little harder for people who have epidurals, or at least providers will say it's a little harder for people who have epidurals, and that's probably a big reason why providers are not as familiar with doing that, because when someone has an epidural, it's a little bit more challenging to get them quickly into an all fours position, although it absolutely can be done. But that would be another option. So thank you, Hannah Rose, for sharing that. Yeah, awesome. So these were great questions, great comments. Thank you guys so much. I want to wrap up there, but if you are attending live, you can just hang on for 1 minute past the time that we end this recording. But yeah, I want to thank you guys so much for joining me tonight. And just know that the recording will be sent out to you automatically. Everyone will have 1 month access for the recording. So thank you guys so much for being here tonight.